Welcome back to part 2 of this program from Regular Cardiology on POTS. We're going to move from diagnosis and the epidemiology of POTS to the subtypes. And I'm pleased to be joined by Mel Lobo from the Barts Health Clinic for blood pressure. Mel, if you could tell us a bit about subtypes of POTS.
Yes, thank you for that introduction, Andrew. I'm just trying to advance the slides here now. So I think it can be sometimes a little bit overwhelming to get into the nitty-gritty of subtypes, and perhaps it is not that helpful other than they help to illustrate really mechanisms that may inform treatment approaches down the line, and you'll see that in a later slide. So on this slide here you can see a variety of conditions in large boxes that are the phenotypes, or as some people prefer to call them, endotypes, so neuropathic POTS, hyperadrenergic and volume dysregulation, and then some associated conditions such as mast cell activation and autoimmunity that can contribute to the orthostatic intolerance. And it's by no means clear to what extent each of these conditions are responsible in their own right in any one patient, and there's certainly overlap between the different conditions within one patient. But let's just have a look at some of the background detail. So for neuropathic POTS, what's become clear is that in a proportion of patients, and really in the studies, there are very, very few studies that have characterized neuropathic POTS. In one study, half of the patients had features of regional autonomic neuropathy, and that was coined in terms of patients with disturbance of sweating function in the distal lower limbs, and proven both with direct sort of neurological measurements, so quantitative axon reflex testing, and also histopathologically with studies from skin biopsy showing reduced nerve fiber density in the skin to account for reduced sweating. But as Leslie alluded to earlier on, with the change in posture, we all will see a certain amount of blood pooling within the abdomen, pelvis, and lower limbs. And in normal individuals, vasoconstriction will see return of that circulation so that you don't have prolonged pooling and you don't have symptoms of orthostatic intolerance. But in patients with POTS, there's clear evidence of dysfunctional circulatory regulation in these regions, leading to pooling demonstrable when people become upright from a recumbent position that's not observed in healthy normals. Pediatric POTS patients also seem to have pooling in the lower limb, which is mediated through arteriolar dysregulation and not just venous. And then there's evidence of a denervation hypersensitivity type phenomenon in some patients who appear to demonstrate excessive vasoconstrictor responses to norepinephrine or noradrenaline when administered compared to healthy controls. So quite a lot of different strands of evidence pointing towards regional autonomic neuropathy in this group. And then in addition to this, we have the other subtype, volume dysregulation, whereby POTS patients are commonly observed to have low plasma volumes. And if you use a accepted measure of plasma volume based upon sodium excretion in a controlled sodium intake state, we can see that approximately 30% of patients may have this low volume state. And it's been proven now that that can arise due to impaired renin-angiotensin aldosterone system regulation, whereby you can have either reduction in aldosterone or renin levels in POTS patients, or even levels of plasma angiotensin II might be elevated, suggesting inadequate ACE2 activity. And so we have various different factors here that point towards a substrate for volume dysregulation. And then you can have additional factors such as loss of volume in hot weather or in dysfunctional GI states, whereby you can have gastrointestinal dysmotility disorders and diarrhea that may compound volume dysregulation. And we pick these patients up sometimes in the autonomic lab with evidence of mean arterial pressure that's very low, so hypotension, which is above and beyond one might expect in a menstruating female of that age. And then the third large phenotype group is those with hyperadrenergic POTS, which is thought to be, again, a variable range up to 60% of POTS patients who have these pronounced symptoms with orthostasis that suggest catecholamine excess, such as palpitations, tremulousness. And in this group, you don't want to miss pheochromocytoma, so you should assay the catecholamines in these patients, and they seem to be worse during periods of physical exertion, and any emotional stress can trigger their symptoms as well. They tend to exhibit profound BP variability when we put them on tilt or active stand as well, and more substantial rise in heart rate. And then they have measurable increase in plasma catecholamines during the stand as well. That's something that's not as easy to assay in the UK, because getting people to have lying and standing tests is not done routinely in most places. So we really lack data from UK patients on this. A nice way of sort of putting it all together is this rather complicated looking diagram, but the key thing is if you see the topmost golden bars with the 3 different major phenotypes, and we see how neuropathic POTS and hypovolemic POTS converge to create a state of reduced venous return, a reduced stroke volume, a reduced cardiac filling that causes secondary baroreceptor offloading, and thereafter promotes increased sympathetic nervous system activity, which we actually get from the hyperadrenergic state as well. So there is this overlap in what these different pathophysiologies lead to, with the final common pathway of the POTS symptoms as listed below, and then contributions from autoimmunity and mast cell activation. And in the interest of time, I didn't think we should necessarily run through any detail on the slides of those, but they're there for the delegates to maybe review later on. And I think Nick touches upon them. All I'll say is that these are conditions that, if one suspects mast cell activation in this group, these patients certainly deserve more specialist evaluation in the hands of the immunologist. And for autoimmunity, well, the truth is it could be of clinical interest, because there are many features to suggest that POTS has an underlying autoimmune basis based upon clinical findings, based upon the fact that there's often a triggering event, based on the fact that autoantibodies have been noted, but the relevance of these autoantibodies remains unproven to date. And at the present time, we haven't got any convincing clinical trials evidence that immunomodulation with various treatments, immunosuppression or antibodies, plasmapheresis is worthwhile from any randomized controlled trials. Thank you.
Thanks, Mel. So 3 broad subtypes. So we have a neuropathic POTS, hypovolemic POTS, and a hyperadrenergic POTS, but they don't sit as simple as 3 baskets. There's overlap, and they're really conceptual ideas on how we should be approaching a group of symptoms within an individual with POTS. So Leslie, when you see a patient, are you looking to divide them up into that, or are you just looking for a collection of symptoms that meets the primary diagnosis?
I mean, very often in terms of the management that I can offer them in primary care, and we'll talk about management in a minute, it doesn't make a huge amount of difference, but occasionally it does. There are certain drugs that you're more likely to use in hyperadrenergic POTS. For example, you might use slightly different drugs if hypovolemia, or different treatment strategies if hypovolemia is more pronounced. And also sometimes it's really helpful to recognise the underlying, if there is an associated condition, because that might have other implications for management of the patient in other aspects of their life. As a GP, I don't have the facilities to test for a lot of these things. So, you know, in the setting of Ehlers-Danlos syndrome, and there's a strong family history, I'm quite happy to get on and manage that. But sometimes as a GP, I have to refer patients to specialist centres if I'm concerned that there's something else that needs testing for that I can't do.
And Nick, it strikes me that there may be several conditions here that can meet the diagnosis. That POTS could be driven by multiple pathologies, but the outcome is the same. Or do you think it's multiple diseases and we're just not sophisticated enough with our definition to divide them up?
I think that's a very difficult question to answer, because we don't really understand what the pathophysiology is. I suppose my own view is that we will eventually discover a number of diseases that produce this. But it may well be different forms of a neuropathic process affecting blood vessels, I suspect, in the end. But it's very difficult to say.
And Mel, you've got a comprehensive testing centre of POTS. I mean, these are pretty sophisticated tests. Are you offering them routinely to the patients you see, norepinephrine testing, and this sort of comprehensive physiologic analysis of your patients? Or are you reserving it for refractory cases?
We're reserving it for those patients that might be compliant with attending for the testing, because a lot of our patients are coming from very far away, and the practicalities are such that it's hard for them to give up time and attend. Even a full set of autonomic function tests for some of them is quite exhausting, and then going through the rigmarole of getting the laboratory to comply with measurement of lying and standing catecholamines has proven really challenging for us. So from a practical viewpoint, less likely for us to do the full biochemical evaluation, but certainly we do the autonomic testing where we can. And to come back to a very important point that Nick just made, I think I agree strongly that to me POTS is really a dysautonomia, and unfortunately it's come to be recognised through this term POTS, which has moved from postural orthostatic tachycardia to postural tachycardia, but actually that's only really an umbrella for what is potentially a widespread cardiovascular and other dysautonomia. And within cardiovascular, we have regional dysautonomias such as lower limb circulation, upper limb circulation, splanchnic, cardiac. But then, we have the complexity of genitourinary, gastrointestinal, sweating, thermoregulation. So it can be a pan-dysautonomia, and that's something that we see in some of our more complex POTS patients. And I guess the bundling that we just came up with in terms of the three phenotypes is useful because people have related to POTS in that way, and it may help you think about treatment in some respect. But the other way to look at it is to be symptom driven, and I'll come to that in my talk on drug therapy.
Okay, well, I think we'll close this section. We're now going to move on to comorbidities in POTS with Dr. Gall.